Now we come to the wisdom as well. To my friend Peter Seferović. Peter, you are the last speaker for the expert. I know this is virtual. This is the second virtual for you with me. You remember the CV rep we had just a few months ago?
Yeah, of course.
Yes, and you promised me maybe next Cardio Alex you will join us. Peter Seferović is going to speak about the novel approach to heart failure treatment between clinical wisdom and clinical evidence. Okay?
Yeah, that's, let me say once again that I'm happy to be with you. Always I come or virtually or physically in your area, I really feel like home. And exchanging scientific information with you, but also exchanging the friendship and the idea how we should improve our patient with heart failure is extremely important. Some of the things which I'm going to present are already presented, but it is important to give the personal view on it. And the bottom line is that we live in a very exciting time for heart failure. Starting from 2000 and from 2010, we have a lot of new trials which help us to understand heart failure better. Obviously, we know that the heart failure treatment is very complex. We are convinced that we did a great step, and in Europe with the heart failure national societies, the implementation of the guidelines is something we need to foster a little bit more. So as it was pointed out in May of 2021, some of us know more, some of us know less what will be presented. However, the problem are not the guidelines themselves, but it's also the implementation of the guidelines within the heart failure national societies. And Egypt is one of the examples how the Heart Failure Society of Egypt should work hard in terms of fostering guidelines and spreading the knowledge of this disease, which is very, very frequent and very mortal. Even with the old treating modalities we have, the risk of cardiovascular death remains very high. And we know that the residual risk in HFEF patient remains unacceptably big, and even the patient are receiving the standard of care we are facing with at least 1/3 of the patient who die suddenly. And this is the things we need to understand, and this is the things we need to keep in mind all time, because sudden cardiac death is something which happened in the people with relatively maintained ejection fraction, and we need to do the stratification of those patients at a higher extent and very precise. We know that guideline-directed medical therapy is not followed, and this is directly related to what I was discussing. In CHAMP HF registry, 2,500 patients were followed, and as you can see, the number of the patient which is not reaching the top target of any of the guideline recommended drug is extremely high. It is obvious that this is due to the different factors, and we can see that the intolerance to the drug, but also strangely enough, the patient preference and clinician preference are playing the major role. Healthcare system based factors are also important, and this is who prescribed the drug and when the drug can be given during the follow-up. However, the major problem here, as usual, is clinical inertia, because most of us are thinking if the patient is doing fine, and we don't need to change anything, and that's completely wrong. We know that the guideline medical therapy is associated with a much better outcome if it is obeyed or in the patient who did not receive the guideline directed medical therapy. In this case, in various geographical areas, in the 6,000 patient in qualified registry, that was a significant difference between hospitalization for heart failure and cardiovascular death, in terms that the patient who were top to the maximal dosage guidelines were living longer and had less complication. However, as it was pointed out, we are happy to live in the changing world, and this changing world is not only what we are having the more possibilities with neprilysin inhibition, with SGLT2 inhibitors, with vericiguat and omecamtiv, but also it's opening the area of insecurity, how and when all these drugs will be applied and how we are going to use them in the setting of our heart failure patient. As I heard in the previous lecture, in the previous discussion, that was stressed, but you never know what brainstorming can give you in terms of better use of those drugs in a different patient subpopulation. Needless to say, sacubitril/valsartan is one of the major important drug in the treatment of heart failure, producing significant reduction in cardiovascular death and heart failure hospitalization, as well as all-cause mortality. The key point, and we were witnessing this these days in analyzing the heart failure hospitalization from the AOR trial, the heart failure hospitalization is a major factor in increasing the cost for healthcare systems, but also increasing the mortality of our patient. And sacubitril/valsartan is one who is decreasing heart failure hospitalization from the first to all next one to the higher extent. I would not go too much into details with SGLT2 inhibitors because it was discussed before. However, I would completely agree with the discussion and the previous speakers that we are now having something which is a breakthrough, which is easy to apply, which is once a day, does not need up-titration, has a significantly low rate of the side effect, it's improving renal function, and all that was shown in Emperor reduced with the reduction of heart failure hospitalization and cardiovascular death, but also the improvement of the composite renal endpoint, giving us the idea that improving heart and kidney axis is extremely important. That was obviously shown also in DAPA-HF, and cardiovascular mortality, heart failure hospitalization, and urgent heart failure visit were very much reduced by the effect of dapagliflozin. However, once again, look at the early diversion of the curves, which is the proof of the very good early effect of those drugs, which is giving us the possibility to apply those drugs very early. We know that they are effective on the top of everything else. However, we know that these drugs may be also used in a different drug than anything else. So SGLT2 inhibitors are the breakthrough, easy to apply, and also improving long-term cardiovascular outcome in those patients. However, ladies and gentlemen, what should not be forgotten is that heart failure is a very difficult and arduous journey. the phases of stable patient and the phases in whom the patient has decompensation are interchangeable, and the stable patient may decompensate and be admitted in ICU or visit the ER in unknown rate and a known number of visits. Therefore, what is important for us to understand that the treatment of heart failure should not be the same in a stable patient and the patient who is decompensating. And also the treatment we are giving, and this is the key point, should be given to the higher extent to prevent acute decompensation of the heart. VeriSig-WaTT was another good example and another positive trial in whom VeriSig-WaTT, which increases SGC activity, improving myocardial and vascular function, and also decreasing oxidative stress but improving endothelial dysfunction, was shown in a very high-risk HFEF patient, around 5,000 of them, with an excellent follow-up in 10.8 months, that easily decreasing the cardiovascular death and first heart failure hospitalization. So both Victoria and the next trial I'm going to present, Mecaptive Mecarbil trial, are the niche trial, but very important because they will probably be used in a group of advanced heart failure patients with a low ejection fraction, with a very high NT-proBNP, and with probably much higher mortality than any other group of heart failure patient. Omecaptive mecarbil, increasing the duration of systole, increasing the stroke volume, but without the cost of increasing energetics of the heart and the expansion of AT-BNP on the heart, is something which is the newcomer. 2 weeks ago, we learned that galactic HF was positive with a primary outcome of composite endpoint of heart failure event and cardiovascular death, which was reached in this trial. Heart failure hospitalization were the major driver of the positive result, although cardiovascular death was neutral. If we look at the different models who are comparing contemporary and conventional therapy, if you look at the decision analytic model and looking at the insight into number needed to treat of the different heart failure drugs, you can clearly see that SGLT2 has a higher possibility to be promoted as one of the most important drugs. And as you can see here, number needed to treat with SGLT2 inhibitor, and this is shown here versus placebo, are representing the additional mortality benefit on the top of everything we are giving. The analyses like this one are extremely important, and this is also applied to the cross-trial analysis of emphasis paradigm and DAPA-HF, in whom heart failure therapy was seen as a conventional and comprehensive, which was defined as ARNI, beta blocker, MRI, and SGLT2 inhibitors. Conventional therapy was carrying the prolongation of life of 6.4 years, and comprehensive therapy 14.7 years, giving the difference of 8.3 years, which is fascinating, that then can be achieved only by the drugs without the devices and other procedures and interventions we can do. However, ladies and gentlemen, as it was pointed out, what the crystal ball is saying us, what is the future of the management of HFEF? Besides what we learned, that activation of beta blockers, ARNI, MRI, and to some extent of loop diuretic, we may look at the further and the future treatment of HFEF in terms of the patient who, after the appropriate dose of beta blocker, has a heart rate more than 70, he may have ivabradine, and if the persisting symptoms are there, on this patient, the digoxin can be added. If the patient has a persisting congestion, then the new diuretic or more diuretic can be added. And if repeated admission, vericiguat or omecaptiv can be used. The place of SGLT2 is here suggested to be central, but it is always the question how, and both previous speakers were alluding to that, how they are going to be used. It is possible that we are going to go away from the on-the-top treatment, and that they can be used as a separate axis in whom this drug will be given. Obviously, if there is a transferrin saturation less than 20, we need to add IV iron and the atrial fibrillation anticoagulant. It seems to me that one of the things which never can be changed, and we discussed that in the previous meeting, is Egypt, is the variety of the conditions under whom heart failure patients are living. The social and economic country-specific factors are combined with the physician education and inertia, but also with the type of health system. And you may recognize that I'm talking only about extra medical, extra cardiology factors, because those are the most important factors, which patient will get which drug at which stage. At the end, I would like to let you know that the new drugs are putting the challenge in front of us. The challenge to know exactly how these drugs should be used, and also the challenge not to overdo with the use of various treatment modalities we have, because we should not never forget that the key to the excellence in medicine is the art of being critical. I would like to thank you very much for your attention.
Thank you, my friend. We're just speaking, this is an international lecture, state of the art, because I asked Lars about changing the guidelines. I think I know what's in your mind to change the guidelines. This could be a stimulus to change the guidelines, starting with the drugs which proved itself, and then up titrated, and then you have now drugs in your pocket for contraction, the rate and the contraction. Thank you very much.
No problem. What we need to understand that the cardiology is a big battlefield. We are not having only the new drugs in the heart failure, but also the new drugs in cardiomyopathies. And you know that we have mevacaptan, the first drug ever which is going to be used of the treatment of the hypertrophic cardiomyopathy. We are going soon to have the result of immunoabsorption in the patient with dilated cardiomyopathy, and we have also the tremendous progresses in finding out the role of amyloidosis in the patient with restrictive cardiomyopathy. So we are moving very fast ahead.
But we are moving in heart failure with reduced ejection fraction. But still, I think we are far behind heart failure with preserved ejection fraction. Maybe the next guideline, not this guideline.
Absolutely.
Yes, guideline.
Absolutely, and you know better than me why is that? Because it may happen that heart failure with preserved ejection fraction does not exist as an entity. It may be the different combination of the comorbidities. It may be also the result of different etiologies. So we may be at the same position like we were with acute heart failure, because we experience with acute heart failure a lot of different failures. And that's because probably it's not one animal we would like to shoot. There are several animals with the same appearance. The same may be true with heart failure with preserved ejection fraction.
I have another question for you, which I think it was asked before, but not for you, regarding the evaluation of ejection fraction and global longitudinal strain, because already the basis of heart failure depending on the ejection fraction, and even if you take these drugs, the ejection fraction improves slightly, but the patient improves significantly in quality of life. So it doesn't matching with this. So I think something is missing. So ejection fraction is not regarded as the sole criteria of differentiating the 3 types or 4 types of heart failure. So I think this is the defect we are missing in heart failure preserved. So we are looking for another criteria which make you that maybe improving the so-called diastolic dysfunction, heart failure preserved, so-called whatever you say. But I don't think the ejection fraction is the proper number that you are regarding this. Still you are considering this is arbitrary for heart failure. What do you think about this?
Let me answer you in these late hours with a joke. First of all, if drug is working, nobody cares how it works. And the question was how SGLT2 inhibitors are working. And we know there are several theories, but nobody really sure what is the theory, but they are working. So they are there. And the same is with ejection fraction. As soon as you told me what else you can do instead of the ejection fraction with the same practical application and with the same massive all over the spectrum of different physicians from GPs to the internal medicine to the different type of cardiologists, I will be happy to hear. The problem is that we don't have something else what will be replacing ejection fraction. However, you're absolutely right. The effect of those drugs are going much more than improving ejection fraction. And the effect which we can see, and omecamtiv mecarbil is probably the best and last example we are having, is on the peripheral vascular resistance, on the neurohumoral activity. And if we look at every particular of the drug we have, we always asking ourselves what will be the subset of the patient we are going to care. And that was the title of my lecture, was alluded to between the clinical evidence and the clinical wisdom. Because the clinical wisdom is something which you get with years, with your experience, and sometimes that could not be black and white situation like with the clinical evidence.
So you advise personalized medicine for heart failure?
Absolutely.
Okay, thank you very much.
But let me tell you how we are going to do that in 100 million people in Egypt. You may have, let's say, 10 million people with a different type of heart failure. I may be right, maybe not. I know, for instance, in Serbia, we have like 700,000 among 7 million inhabitants, different types, asymptomatic ones, preserved ejection fraction. So it's very complicated, and as it was already pointed out, I believe that the role of your association and the role of our common activity is to educate and to spread the knowledge about the best diagnostic, but also the best treatment options.
Thank you very, very much for this state-of-the-art lecture. I hope to see you very soon. Have a nice weekend.
Thank you very much.
Bye-bye.
Let me say that the pleasure was once again mine, and I really appreciate your invitation.
Thank you. Bye-bye.
Bye-bye. Bye-bye.